Okay, ladies and gentlemen, you're very welcome to this session, which is supported by Broome Biometrics. And I suppose since we were here this time last year, so much more evidence has grown around subepidermal moisture measurement that it's a really exciting opportunity to be here today to provide you with the update of the information and really placing into context that the idea really is that when we make very small changes, we can significantly enhance our clinical outcomes. So small changes leading to better outcomes. And what we're going to be talking about today is Jacqui's going to really talk to us about the fact that there are challenges in the current risk assessment. And we've been talking about this for many, many years. And if you think today that there are over 90 risk assessment tools out there in practice, it really should lead you to question, well, why is that so? Really, if there are 90 there and they're all supposed to be measuring the same thing, why would we have 90? And then somebody would argue, well, of course, that's because we need one for pediatrics and we need one for older people and we need one for orthopedics, for ICU, we need one for theatre, we need one for the outpatients or whatever. But the reality of the situation is we really need to come back to the basic idea around risk assessment and ask ourselves, as Jacqui will allude for us, what are the current challenges with the risk assessment and how can we possibly move the agenda forward in this area? And then Jeanette is going to talk to us about some real live evidence from randomised controlled trials and also from her own experience. And that's really going to place into context what Jacqui will be talking to us about and really putting like a hand in a glove together, getting the whole idea and the whole evidence base and saying, well, where are we and how should we move this forward? So it's a great pleasure really to be here because what we will be doing is then wrapping the arms around the whole concept that small changes can make better outcomes. So it's a real great pleasure to introduce our first speaker, who is Jacqui Fletcher, and I'm sure absolutely that nobody really needs an introduction to Jacqui because Jacqui is such an amazing advocate for this whole area of tissue viability. So Jacqui's an independent nurse consultant, and as I said, Jacqui's going to talk to us about the challenges with current risk assessment. Thank you, Jess.
Good afternoon, everybody. For me, it's always a pleasure to talk about my favourite subject, which some of you will know is pressure ulcers. So I'm really looking forward to doing this session. And as Zena said, we're going to be split into two sections, and I'm going to talk about the risk assessment tools. And my question to you all is, do you think we're overcomplicating pressure ulcer risk assessment? Anybody in the room agree that it's just too difficult? So I'm starting from a very positive point that you all agree with me that we're kind of messing it up. And I have to start by declaring my conflicts of interest. This is a commercial symposium, but as you can see, I work for many different companies and the views I'm going to present are my views entirely. So when we talk about risk assessment, what we are working towards is the fact that many pressure ulcers are preventable. And you'll notice I've very carefully not put on that slide 95% of pressure ulcers are preventable because I don't believe that that's the case. I believe we talked about that for a long time, but that has changed significantly. But what we do need to do is continue to make good use of our resources and maintain patient comfort and dignity. And that in order to do that and deliver care in a timely way, we need to identify the patients that are more at risk so that we can target interventions to do that. And in order to do that, we've developed this whole range of tools that, as Zena mentioned, are some generic, some really specific, to try and pick out the things that we believe make those patients be at risk. So this isn't a comprehensive list, this is just to give you an example of there are some, like Waterloo and Braden and the newer tool Purpose T, that are aimed for generic use. We think we can apply them to every patient in our population, whether that's acute or community. And then the very specific ones that look at particular risk factors. So for example, in paediatrics, is an 8-month-old baby incontinent or at a normal stage of their development? How do you record that within a Waterloo tool? So those have really specific things that they've chosen to pick out to help us to focus on that group. In the intensive and critical care, they look at things like use of inotropes. My personal view is that I don't know why we have pressure ulcer risk assessment tools in intensive care, because if a patient's in intensive care, I would suggest they're at risk of pressure ulcers because they tend to be very unwell. So we then have to ask ourselves the question, and Lee in the earlier session was talking about measurement, is do these risk assessment tools work? Because if we are going to make good use of resources, we are one of those prime resources. And if you go to the literature, what it tells you is that there's no reliable evidence that the structured use of a risk assessment tool reduces the number of pressure ulcers that happen. And we've seen many challenges over the time where people have tried to do literature reviews that say, does use of a risk assessment tool reduce the number of pressure ulcers? My immediate response to that is a risk assessment tool is a piece of paper. A piece of paper doesn't prevent a patient getting a pressure ulcer. It might now be digital, but generally speaking, it's not the tool, it's the interventions that make the difference. So if the tool is going to trigger intervention, we need to know that if it's worth that time, effort, and energy that the clinician is put into assessing that risk, and then implementing the resources, whether that be equipment or repositioning or skin care or other supportive interventions that are triggered by an objective measurement of the risk. And if you look at the studies, so for example, Crean and Brindle in the States found that in their review that staff frequently recorded a risk score in the documentation but failed to enact interventions to prevent pressure ulcer development. Now you can look at that and give the big sigh and say, oh, they just don't deliver the care. Or you can be real, clinically real, and say, how many nurses do you know who do things but don't document them? Because that's actually the priority, isn't it? The delivery of the care rather than the documentation. So is this true or false, that they are documenting but not doing, or are they doing but not documenting? And which is the better? Is it a positive or a negative? So my real question is about, are we focusing on the risk assessment much more than we're focusing on the management of these? And this is some feedback from a group that I was recently involved in. We talked about, do the risk assessment tools work? And the clinicians involved said they were really struggling with their organisation because at their trust, they were meeting the NICE target of assessment within 6 hours, particularly when patients followed particular pathways. So when they were audited on their risk assessment documentation, they failed miserably. But the pressure ulcer numbers hadn't gone up. And when you looked at the care that was delivered to the patient, it was perfectly adequate. So what they were saying is assessing whether the risk assessment has been done does not mean anything in relation to whether the preventative care has done. And I think for many of us, that's a challenge. It seems that we are measuring the things that are easy to measure rather than the things that make a difference to the care that the patients receive. And in this edition of the journal that you'll find out and about during the conference, the debate was about, does risk assessment influence care? And one of the questions was, does it lead to the planning of care? And you can see from 3 of the respondents there, very much this feeling about the risk assessment tool being a tick box exercise, and that people focus on doing that rather than guaranteeing an appropriate plan of care or delivering that plan of care. And that there being a disconnect between what they do, which is seen as a piece of paper thing, not linked to the patient, rather than something that's about that patient and that patient's skin. And the challenge for me is that when a risk assessment tool is seen to not work, and we measure that with sensitivity and specificity and positive predictive values, not does the patient get the pressure ulcer, all we do is make another one. And you've all heard that quotation, if you keep on doing what you always did, you'll always get what you always got. And I kind of feel we're a little bit in that scenario. And we've mentioned today the Facebook group. There has been at least 2 occasions, discussions about, has anybody got a risk assessment tool that does this? And the number of people who've said, we're just developing a new one, we're just adapting. What does that tell you about the risk assessment tools? Some of them are using screening tools as precursors to the risk assessment tool, so they're kind of taking a top layer of people out to try and save some clinical time. So when we're talking about these risk assessment tools, we really need to think about how do they lead you to deliver an intervention, because that's what they're meant to do. The purpose is that they target that resource to the right patient. But all the guidelines, whether that's the UK guidelines or whether that's the international guidelines, emphasise the role of clinical judgment, that it should always be a key element in assessing the patient's risk. The challenge with clinical judgment is it can be very difficult to document. And when you're doing a root cause analysis or when you're studying court, how do you defend that the risk assessment tool said this, but actually it was my belief that the patient was somewhere else? So we're starting to look at newer ways of identifying at-risk areas rather than just doing these generic risk assessments. And we need to really think, and I hope you noticed I managed to get the tiaras in. It took me ages to come up with something that said tiara. That timeliness is really important for appropriate risk assessment, because I talked about this 6-hour standard. We must be doing risk assessment as soon as possible. We must be implementing care as soon as possible. Because what we see is that in skin inspection, there's sometimes a delay in visual inspection in finding the damage that's happened to the patient. And many of you will have seen this diagram, which looks really complicated, but really what it's saying to you is when we're talking about pressure ulcers, there's lots of damage happening underneath the skin. So when you apply mechanical load, whether that's pressure or shear to the skin, all that damage caused by deformation happens beneath the surface. And there's this kind of damage threshold. If we can intervene before that happens, then the damage is much more reversible. But what we tend to do is look at the skin, and only when the skin is red, so damaged, then do we see there's a problem and start to think about intervening. So we're going to go on to talk about subepidermal moisture, and Zena mentioned how much further on we are in our research on this, but I want to present some pieces of work that Zena and her teams have done, just to quickly give you an overview of it. And for those of you who are not familiar with it, SEM is related to skin and tissue water, and you measure it through electrical capacitance. It's all about the skin battery and being able to measure that flow. And we know that a healthy tissue is not normally inflamed, but the tissue that's had pressure damage will be inflamed. You know that because when you use a visual inspection, you also feel the temperature and the tissue turgor. And the more water, the higher capacitance and a higher SEM number, and the less water, the lower capacitance and a lower SEM number. So this is the scanner, if you haven't seen it, and it determines the level of subepidermal water. So at that threshold that I was showing you, this is measuring what you can't see visually through a signal picked up by this electrode when you place it against the skin in the areas deemed to be at risk. So these are the papers from Zena's team at the Royal College of Surgeons, and they did a variety of studies, but I picked 2 particular pieces to just show you. So you can see this is done in older patients, 65% female, and a large percentage over 81 years. But I really want to pick up on those 2 bottom graphs. So if you are doing a weekly Waterlow score, the score for that patient may not change over time. But you will actually see that the patient's condition may have changed. But the numbers are so lacking in sensitivity, you don't see a change. Whereas if you measure the patient's SEM, it responds to the fact that they've been moving or not been moving, or to the fact that they've been in one position for a longer time. So whilst the Waterlow is static, you can see the SEM scores are changing and fluctuating with changes in the patient's condition. They also looked at the comparison between the SEM score and the nurse's visual assessment of the patient's skin. And again, you can see these are patients and at-risk adults, 47. Data were collected for 20 days, more females than males, elderly, mean age of nearly 75. But what it very clearly identified is that compared to visual inspection by nurses, that the SEM scanner was picking up skin damage on average 5 days earlier than the visual assessment was. And therefore the interventions were either allowed to be put into place or, hoping that they had intervention anyway, escalated, or even targeted to a specific area of the body. So if it's only a heel that's at risk, the patient doesn't necessarily need a much better mattress, they may need a better heel protection. And this was allowing this to be observed and managed at a much earlier timescale. So to summarise, we can't just keep creating new risk assessment tools. The time and effort put into testing those risk assessment tools is not warranted or justified when we can't see the link between assessment and practice. And we need to do something that clinicians see make a difference that actually affects the patient, isn't just another thing to be audited. We need to remember technology is increasing, and technology will never replace nursing, and it will never replace clinical judgment, but increasingly it is important. But because of that, timeliness is also important. So 5 days is a significant difference. We need to look at the evidence from the real world, which is compelling, and that's what Jeanette's going to talk to us about, because it gives us an opportunity to change the way that we manage pressure ulcers. And that's going to be work that's not just been done here in the UK, but also internationally. And there is a real range of data already available. And it's not just clinicians who are seeing this change, it's being recognised in a variety of organisations, in a variety of awards, and by a variety of clinical areas as well. So there's a wealth of data there to support this technology. Thank you very much.
Thank you very much, Jacqui. So now it's a great pleasure to introduce Jeanette Milne, and Jeanette is the lead nurse in tissue viability in Northumbria Healthcare NHS Foundation Trust. And as you can see from the title, she will talk to us about risk assessment tools, timely detection and prevention.
Thank you, Zena. Thank you, WUK, for inviting me, and thank you, Brune, for supporting this symposium. My conflicts of interest, you can see there that I've been paid by a number of commercial companies, but again, the work here that I present is my own views. And really, I just wanted to challenge myself and you in the audience here. We know that the population is ageing. We live and breathe that if you are clinicians every day. 20% of my sequin data shows that the majority of my population are over 70 and 12% of them are over 90. So that population is ageing that we're seeing in the UK. And there is an international agenda to reduce pressure ulcers. Interestingly, when talking to my comms team about my pressure ulcer campaign for November, they were, you make some massive assumptions there, Jeanette. And I'm like, well, pressure ulcers aren't sexy, I think was the thing that I said. You know, have you had one on your bottom? Perhaps then you would maybe refocus and put some weight behind this campaign. But I would argue that we haven't necessarily reduced overall numbers. Reports, like Jenny said this morning, have showed that we have flatlined in the UK. And in essence, what we've become good at is arguing when they were and were not caused by poor care. What we're good at is looking at skin, and we're good at implementing blanket programs. Risk assessments, or RATs, I love that, Jacqui, never heard it being called that before, but RATs are good at helping us introduce blanket programs. But it's really about increasing awareness, and I think we've been really, really good at increasing awareness of staff, and it's stopped the pressure again this week. But we are striving for excellence, and I like this quote from Aristotle. So my first introduction to the scanner was, can we do things differently? And for me, it was about running the gauntlet in this 008 study. We were asked to take part in this study as a UK arm of an international study, and it was specialist versus technology. So I was the specialist that was blinded to the results of the scanner. So I was directing care for the patients in this study, and a generalist colleague was scanning patients, and I didn't know what the scan results were. I could purely look at the patient's skin and their risk assessment. And we also collected metrics on skin tone. So I suppose the study overview was that it was a multi-centre prospective blinded study, and they recruited 189 patients in that from 12 sites. Essentially, it was the deviation in the delta of the scanner versus the visual skin assessment, which is currently the standard of what we do. We visually inspect patients' skin, and we direct care based on that assessment. And essentially, it was the time at which the delta was reached versus the time at which visual skin inspection would show a pressure ulcer. And that delta with the scanner was 0.6 or more. So in that study, quite matched in terms of male-female participants, and you can see they had a range of different skin tones included. And there was actually an intent to try and include different Fitzpatrick skin tones in this study. And that is because we all know that it is very different and more difficult to detect skin damage in non-Caucasian skin tones. From an inclusion and exclusion criteria, the patients had to be over 55 years old, at risk of developing a pressure ulcer, and obviously immobile for 4 hours or more per day. Obviously, exclusion criteria was a recent or recently healed pressure ulcer at any anatomical site, and the scanner was used over the sacrum and the heel areas of those patients. And perhaps surprisingly, or perhaps not so for yourselves in the audience, but 55 patients developed pressure ulcers. So that's a third of these patients developed pressure ulcers, which were visually assessed. And you can see there the breakdown of where those pressure ulcers were. However, the interesting thing for me was, borne out in Zena's and previous studies, was on average the scanning provided 5 days of advanced detection. So that scanner could see and predict that damage occurring in the patients 5 days before I could see it. So as such, it really gives nursing personnel the opportunity to make informed, targeted and patient-centric decisions, like Jacqui said, perhaps only targeting the heel of the patient as opposed to giving a mattress. However, if we blind clinicians to those interventions, damage still occurs. Perhaps react to red is reacting too late. And for me, it should be about acting at the earliest point to enable prevention. Essentially, 2 of the 10 patients that I looked at developed damage. And whilst I could probably have identified that all of those patients were at risk, and my get out of jail card, I guess, is also that I wasn't there 24/7 to deliver the care, the reality is that 20% of my patients that I was looking at developed damage. So my question to you is that if I with my knowledge, again, debatable, some of you who may know me well might debate my knowledge, of anatomy and physiology and patient behaviour and risk assessment, and the equipment is out there, can't get it right, what chance has the generalist got? So this is me running around, scared of the scanner, on the right-hand side here of this slide. But do we need to do things differently? Can we challenge ourselves to do things in a different way? Is what we're doing good enough? Jacqui's already expressed her views on risk assessment, and perhaps I think the best risk assessment tool that I've come across recently is almost Ramstadius. Can they move? Will they move? And those 2 very simple questions. And I would almost like to see that replace some of the risk assessment tools that we use, because it's quick, it's timely, it's something that can be answered and questioned time and time again, as opposed to going back to writing a number on a chart. And of course, whenever there's new technology, we need to think about how we embed that in practice. And we also need to think about how we fund that. But really, there is money. Even though we were working in times of austerity, there is money. We have money within the silo budgets. And that perception that there is no money, perhaps if we can focus our care towards prevention as opposed to blanket programs that purport to help with prevention, but really sometimes impede that, like some of the work that we did with the Pressure 2 stuff that I'm sure is going to be published shortly, which shows that patients struggle to move on alternating pressure mattresses. Now, I'm not suggesting that alternating pressure mattresses should never be used for patients. I'm not suggesting that at all. But if we could have much more targeted, we could free time and free resources and gain patient benefit, which would enable us the cash to purchase new equipment. So is there an opportunity to do something differently? Obviously, we were in a very controlled, randomized trial that I talked to you about before. So what I wanted to do with that was see if there was a real opportunity in practice, going back to Zena's studies that Jacqui presented and some of the others that I'd written in the press. Was there an opportunity to make targeted intervention decisions and engage my clinicians and encourage patients, really, to know their own numbers? We all think we do it well. And really, connecting that acute and community use, what would that look like? So, as with everything I do, I never really try for anything that's easy. We looked at our wards in Northumberland, and we have 1,000 inpatient beds. So what did we decide to do? We decided to use our ortho trauma ward, which had the highest number of pressure ulcers recorded of all of the wards in the trust. So, why start with something easy? That trauma orthopaedic ward is at our new emergency care hospital. So you might be surprised to know that the average length of stay there is 3 days, but that's not to say that the patients only stay in hospital 3 days. It's just that it's a 27-bedded unit, which is for trauma orthopaedics only, and post-operatively those patients would transfer out quite quickly. But we did have high numbers of pressure ulcers. And there was the suspicion that some of the patients have damage prior to admission. So you can see here, this is just a simple run chart. This ward also had been identified to be part of our Academic Health Science Network regional collaborative, which was established in April of this year. So that collaborative was using QI methodology with the ward and the ward staff to try and get them to recognise small PDSA cycles. But really, they had 27 hospital-acquired pressure ulcers in the previous year. The median was 2 per month, and maximum of 6 in January 17, which is probably when the winter pressures were kicking in last year. But essentially, you can see there, when they first started on the Academic Health Science Network journey, their HAPU rate went down to 0, and then it steadily climbed and kind of peaked and troughed across that graph at different things that they've done. They've done a lot of targeted heal intervention with the Academic Health Science Network work. But we introduced the scanner, and I appreciate a simple run chart is not a clinical trial, but you can see there in the 2 months that they scanned, there was definitely an improvement in their rate, and they went down to 0, and that was including category 1 pressure ulcers. Because we actually did category 1 through 4 in the organisation. So what did the staff feel about this? Because it is a really busy ward, this ward. And the acknowledgement was, you're asking us to do something else on top of what we were already doing. So the experience of the scanner was well accepted by the staff, as can be seen on this chart here. And they've seen a benefit throughout the evaluation, and they're driving to adopt that in their clinical practice. And we're currently looking for the cash releasing savings to be able to put that business case together. But that's not just my experience, I suppose. The experience really bore out what we were seeing or what we felt in practice. You can see here that 58 of the 59 patients scanned had a high deviation to the SEM on admission. And that perhaps is because, similar to things that you are seeing in your practice, a lot of these elderly patients will have a long lie before they come in to hospital. A lot of these patients will be have tissue damage that we simply can't see. But I think what this also shows for me is that Ward 1 provide good care, whereas previously they'd been in the spotlight to suggesting that because they had a high number of hospital or purported hospital-acquired pressure ulcers, they were seen to be in the spotlight for not providing good care. And you can see there that there are still challenges to be had within the organisation, because one patient with that deviated SEM went on to develop a category 3 despite interventions, and the patient had declined pressure relief. But as they transfer through the system, we probably have some lessons to learn about what that SEM meant to other receiving wards. And obviously, interestingly, because we have a database of all of our patients, we could track that some of the patients that had been admitted had had previous damage in previous years. And that always rings true to most tissue viability colleagues, but I almost think that patients with previous pressure ulcers should have a warning sign on their head when they're admitted to hospital, because that's sometimes not borne out in the risk assessment. But generally, we had no hospital-acquired pressure ulcers on Ward 1 during that 8-week evaluation period. If you look at the different literature that's out there, this is just a poster that is actually being presented at this conference. This is Glenn's work from the Isle of Wight, and you can see there he has had a huge reduction in the hospital-acquired pressure ulcers. And the same is true of Scarborough Hospital in Canada. And really what they wanted to do was look at the Hawthorne effect. Was it just having the scanner that made a difference, or was it actually scanning the patients? And what they found was it was scanning the patients. A further call out really is that perhaps the scanner is the first time in 10 years of my practice where I think that it challenges what we know about pressure ulcer management. And, like Glenn says here, so these are just 2 quotes. And I challenge you all to think about how we can embed this in practice to make a difference for our patients. And perhaps the last thing is a call out to the company, because a lot of the data has been in relation to hospital-acquired pressure ulcers. But as you can see from this data here, the one thing that I want to call out to you is the top thing on the bar chart there. 447 of our patients come into our care with a pressure ulcer where there has been no previous engagement with health other than their GP. So I guess for me, it's how do we impact on that? And that's for all of us to think about how we engage with the public in relation to pressure ulcers. When we do campaigns, it's very much that they're bed sores, but clearly it's not. All of these patients are in bed. But also, there is really, I'm looking forward to the definitions, Jacqui, because there's no standardised approach to when we call a community-acquired pressure ulcer. How many visits does the community nurse need to make to those to make that call out? But what would this look like? This scanner is easy to use, and could it be used by care agencies to scan people? How frequently would you scan people? Is it a once-a-week scan if it's given you that 5-day? Is it a Monday and Friday scan? I don't know, but I think that is now where they need to build their knowledge, because we want to go towards 0 pressure ulcers, not just 0 hospital-acquired pressure ulcers, in my humble opinion. So in summary, just to kind of bring together this session, we've looked at the limitations, or Jacqui's looked at the limitations of current risk assessment tools. I've suggested to you that there is an opportunity to change how we manage pressure ulcers, and really think that early detection is the key. And there are some patients throughout this journey that have said to me, I'm up and I want to be up because they've told me that I'm going to develop a pressure ulcer, as opposed to the fatalistic view is I already have a one. And improved outcomes are achievable, and the real world evidence is starting to support this. And obviously that potential from those savings made in treating pressure ulcers and the silo budgets would help you pay for this innovative technology and more. Thank you for your time.
Thanks very much, Jeanette. Do you want to come back over here for some questions? So does anybody in the audience have any questions? I've got a few, so is it okay if I just start while people are just getting their thoughts together about it? Jacqui, in relation to risk assessment, I'm always arguing about the importance of the risk factor must relate to the pathology of pressure ulcer development, like pressure and shear. Now, if somebody was saying, I wonder, does Zena have hypertension? What they would do is that they would record my blood pressure. So if you were wondering, is Zena at risk of pressure ulcer development, or is Zena developing a pressure ulcer, then surely we need to know what's happening in the skin in order to be able to understand that properly.
I wouldn't disagree, Zena, and I think the challenge has been that in the past when we've put that question forward, the technology we've had to measure that, we've always looked at hypoxia for a start, so it was always about pressure, never about shear. And we've always tried to look at hypoxia, and if you put an oxygen sensor between the patient's skin and the surface, then the concern is that you're putting something that focuses the pressure, and is it the response to the sensor that you're reading, or is it the response under the skin? Whereas with what my understanding of the sensor, what you're doing is a bit like measuring an HbA1c rather than measuring a single blood sugar, is you're measuring what's happened over the recent period. And what we are doing is actually looking at if what we have done or if what we're going to do changes what's happening within the skin and the tissues.
Exactly. So question from mic number 3. Yeah, I see you, yeah.
I can't see the number.
Okay.
Hi, my name's Heidi Sanders. I'm Tissue Viability Lead in Hertfordshire Community. I was wondering if any of the panel or anybody in the audience has any experience of using the scanner in the community setting within the home rather than residential home or community hospital.
Well,
So I haven't personally, and I think that's the call out, that's the big thing for me, that I don't know quite how that would work, how it would work, how many scanners you would need, who would hold that scanner, who would scan people. I know it is something that I've engaged Bruin in and challenged them to try and help us.
Yeah.
we have experience of that. I have to say, though, from a research perspective, but nonetheless may provide some enlightenment for you. So what our student Emer, it answers one of the call-outs that you had around patient education. Emer developed a fantastic education programme for people who were not engaging with health services. So they were in like daycare centres and areas like that. She went in and she met them and she recruited them there, and then she assessed them back in their home. And what she did was that she ran the SEM readings on them for a couple of days. And if she found that they were okay, then she only ran that maybe once a week or once a fortnight after that. Now, for Emer, the primary outcome was knowledge of pressure ulcers for these lay people in the community, and the SEM was a secondary outcome. But nonetheless, it just provides some enlightenment as to how she approached it, because clearly you can't be knocking on every single door in the street to see whether you need to do the SEM readings. But to answer, to get to what Jeanette was saying, it's important for us to capture the people, those 447 who are coming into hospital with pressure ulcers. And it does give a method for doing it. And the other interesting thing was, you had said that care assistants were doing the readings. So it's important for us to know how we can empower other members of the team. And we're really driving forward for patient-led assessment of themselves. And I know that might sound extremely futuristic, but Bruin have been doing a lot of work about modifying the SEM scanner to make it much more user-friendly. And our goal really is, at the end of the day, that the patient or somebody in their home could do the readings. And then if you were able to get that reading, onto your own system, then you would know whether you needed to call to Zena or Jacqui, which one of us it was. So I think that we are moving forward with that because of the call-outs that we've been doing. So there is light at the end of the tunnel in that regard. And Jacqui?
I also think, Heidi, that if you look at some of the work that people like Nikki Elwood-Button are doing with the pressure mapping, there's a real role for it in engaging patients who we perceive to be non-concordant, where you can actually demonstrate them what a difference an intervention makes. You can objectively show them that if you do this, this is the difference, and this is what we know it means. There may be a role there. It may be a limited number of patients, but if they are your really challenging patients, then it's probably worthwhile.
We're looking to do a pilot in a couple of GP surgeries, actually, where we're going to leave risk assessments out for them to do a self-assessment while they're there, just to see if that is one way of capturing interest. That's a couple of GP practices have agreed to do that with us. So.
That's really interesting.
You'd be amazed at how interested people are, because, as I said, Emer just went into regular daycare centres that people were just visiting once a week, and she got a massive uptake from the patients, and they loved it, and they really did get engaged and involved in it, and people around them in their home did as well, because then they started to say, what are you doing there? So there are ways of doing it, yeah?
Thank you.
Question here from number 1. Yes,
Hi,
that's you, yeah.
My name is João. I'm a practice development nurse in critical care. Very interesting, this one. It's a very interesting... We're used to machines, right, in critical care. We love them, and a machine comes out and we look at the number. I'm not sure if this is a question, because on a first approach to this problem, it looks like we're still reacting to a difference. So we only are able to see that a change has happened already, and then the number changes, and then you'll react to that. But probably, as you were saying, especially in communities, if you use a machine, which is something new, that will attract attention from people, people like it, you can get the grandchild to go and scan their granny or something, and then you try to educate people using that machine. That probably is an opportunity, I'm sure, because it looks like we need to use the numbers that the machine gives us, but also educate people on how to have an healthy diet. Using your example of blood pressure, I don't really want to know if I've got a blood pressure high or low. I do have, and I do know it, but I don't care. But I'm running every day to try and prevent the effects of that. So if I'm giving this machine to someone together with a pamphlet to say, make sure you get your broccoli and make sure you've got your proteins, make sure you go for a walk every day, and the opportunity to tell them that is this machine, then bring them on. I'll buy one myself.
Absolutely.
Thank you very much for sharing.
It's a very, very good point, because at the end of the day, it's about prevention. But I just wonder if you, Jeanette, would clarify what you mean by the deviation.
So with the scanner, you scan the patient in several points, and the scanner actually works out whether there's a deviation from the patient's norm. So it's not a defined number for everybody. So as such, I think the best example of that is that it would still work with somebody with edematous skin, because it would be the patient's own deviation. And there is some emerging work to look at higher deviations and putting more intensive care in place for those patients.
I did also want to just come back to the point you made just about how one of the patients went on to developing a stage 3. Because it is important to note that if you did have somebody who had a really prolonged period of immobility, and they come in and they have an elevated a deviation that we are worried about, remember that in some of those cases, you may not be able to reverse that because the damage is already there. And I think that's important, so that it highlights the importance of the scanning on admission to identify the deviations, and some you can reverse and some we will not be able to.
I think I struggled with that, and I think when we were doing the presentation, it was kind of like, do we put it down as one or do we put it down as none that they developed? But when we got the information back that said that 58%, including that lady, had a very high deviation, I felt more comfortable in putting it down, and that she had really good care.
Yeah, exactly. Because as I was at a presentation at the weekend, and Ahmed Geffen was reminding us of the importance that ischemia is slow and cell deformation is fast. So of the 58 people that you had, they will respond differently. But the key thing is that we know what we're looking at on day 1, whereas previously we wouldn't have had a clue of that until 5 days later. Whereupon everybody would have said Jeanette didn't give good care, which wasn't the case. Do you know what I mean? So number 3, yes?
Oh, hi. I'm not sure if this is a question. I'm Claire Webb. I'm clinical lead tissue viability at Bradford. We were just thinking about how we would implement this in community. A little bit what Heidi was saying, really. And we were having a bit of a chat saying maybe it's more of a primary care thing, so where the GPs are going out and you were saying like you would take a blood pressure or do some OBS, then maybe the community matrons and the complex care teams, it's something that they need to pick up on, and are really, when you've got patients who've got quick changes and they've deteriorated quite rapidly, they need some interventions putting in. And if the GPs or the community matrons are going out to see those patients, they can flag that up with the district nursing teams. And it also kind of closes that down, not making it a district nurse problem. It makes it's everybody's problem, physios, OTs, everybody. And I kind of think this is maybe something that would help that change.
I agree with you, because the point as well is that we have to watch out for the people who haven't got the district matron, who haven't got anybody, and by providing education for everybody, then, as you rightly say, everybody's together in the team. whether you are in direct care, receipt of care or not.
It's unfortunate the previous speaker in the last session didn't come, who was a paramedic, because one of the things we've been talking to them about was the number of patients the paramedics get called to who don't get admitted. So 40% of the patients seen by a paramedic is never admitted. And depending on what the problem is, they will do some kind of vague referral to the community nurse that says, I went to see Mrs. Smith, and could you maybe pop in at some point? But what he was very clear about when we started talking to him about pressure ulcers was a sudden realisation that actually it was every contact counted. And if that patient was changing enough to warrant dialing 999, maybe there was something they could do to flag an earlier intervention and raise the profile. So it is, exactly as you said, it's not nurses, it's LTs, physios, paramedics.
And I think for me as well, we've got that opportunity, I guess, because when we are looking at that, if 42% of people aren't getting admitted, that's a lot of referrals into district nursing. How do they then triage those referrals and make it the kind of, who do I need to go and see tomorrow? Who can wait till next week?
That's why our vision was, like, one of our main aims is to get an education programme for people who are living independently, who then, through that system, using something like the SEM scanner, would be able to alert somebody then that it's changing, you need to come in. And the others are okay, they're doing fine, because as the other gentleman said, they're walking, taking their exercise and everything. So, there's a lot to be done, because in the future, we all want to be at home, we want to be active and healthy, older people, but we need to think about the systems that will enable that to be achieved. So we're out of time, and I really want to thank our two speakers for really enlightening us now, and as we said, putting the arms around the fact that small changes can make a really significant difference to patient outcomes. Thanks once again to Brune Biometrics for organising this session, and to all of you for your attendance. Lots of food for thought to discuss over the coffee break. Thank you.